Are we ready to go? Are we live? Thank you, and good morning, ladies and gentlemen, and welcome to today's Health Scrutiny Committee meeting. My name's Seamus Quilty, and I'm the chairman for today's meeting, and all the meetings, actually. So there we are. I've got some announcements. Due to the coronavirus pandemic, the council will be holding this meeting electronically in accordance with the relevant regulations. Members of the public may also attend this meeting in electronic capacity, and there is a link on the council website for them to do so. Members of the council are asked to keep their microphones switched off until called to speak and switch their microphones off once they have finished speaking. Cameras may be left on throughout the meeting if members wish. If you're experiencing connections or other technical issues, it may help to switch your camera off. Cameras should be switched on if and when speaking in the meeting. To indicate a wish to speak, members should use the raise hand function and use, this function is, and please don't use the chat function because it's exclusively for voting. At the end of each debate or agenda item of business, there could be a vote, and if there is a vote, members should vote using the meeting chat function by indicating for, against, or abstain. I will declare the result after each vote. There will be breaks built in, comfort breaks built into our meeting, but I was suggesting maybe about an hour and a half in, but I have to say though that the recommended situation is that breaks of at least 15 minutes be held every 2 hours and will be taken after a speaker in the debate has finished speaking. If we are voting, the vote will be concluded before the break is taken. Other breaks will be incorporated as appropriate. So that's quite clear, but I was thinking around about 11:30 myself personally. Now, do we have any membership changes or apologies? Well, I haven't received any, so we're all here, hopefully. So we move straight away into the approval of the minutes of the 18th of December 2020. Can I ask you to approve the minutes in the chat box, please? Have we all agreed? All agreed? Right, it's all flowing in and it looks like as if it's all agreed, so that's fine. And there's no one that's... Has anybody got any objections in relation to those minutes, or no? You're all fine.
Majority have agreed.
Okay, fine. That's fine. Let's move on then. Agenda item 2 is the public petitions. We've got none received. Agenda item 3. This is the actual starting the work of the meeting. I hope Dr. Jane Halpin is with us. Jane, are you there?
I am indeed.
Great. Okay. Now, if I can sort of slightly change the agenda running for you. You're going to start off with agenda item 3, and then as soon as we're finished agenda item 3, we're going to go on to agenda item 5, which is your other sort of presentation. So that will actually help you in and also help the flow of the meeting. So Jane, it's over to you. We're doing COVID vaccination across Hertfordshire and West Essex integrated care system. Right, over to you to deal with that. Thank you.
Super, thank you. So as the paper that was submitted outlines, what I've pulled together in the written documentation for you is an overview of the programme, which clearly had to be written in time for the papers to go out, and therefore is around about 3 to 4 weeks ago. I thought it might be helpful to also this morning bring a short presentation just to give you some of the data about where the programme is at now, and if that's all right, Chair, I was going to suggest that I do that and run through, and then I'm sure there'll be plenty of questions.
I'm sure.
If you bear with me 1 second while I just pop that into the box. Right. Now, hopefully people can see that.
Yeah.
Yes, it's with us.
Super. Right. So I'll run through the presentation because it makes more sense to do it all together. So we have a number of vaccination sites across Hertfordshire and West Essex, and they are shown on this overall slide. They fall into effectively 3 categories: the large-scale vaccination centres, such as Robertson House, Watford Town Hall, which are available to the public who are invited to book vaccinations currently by letter in certain age categories to be able to book in should they want to do so at those sites. And there are a much larger number of sites run through our local primary care networks right the way across the patch, which are essentially groups of general practices working together, and they invite patients registered with any of those practices, again in the relevant age cohorts, to be able to attend and receive vaccination. We also have a number of community pharmacy sites, so local high street chemists essentially who are also offering vaccinations. So I think what you can see is there is widespread coverage, particularly for obvious reasons around the bigger population centres. The programme nationally has been delivered in priority order, starting with care home residents and workers, and invitations are currently going out to cohorts 8 and 9 to book in, but the people being vaccinated currently are predominantly cohorts 6 and 7. The rationale for the cohorts is to prevent as much serious COVID illness and death as possible, hence the working through the age categorisation. We are this is the first dose target dates is the national sort of estimation at the way things are going. Should vaccine supply be now more fulsome, we would anticipate probably being ahead of that schedule. In terms of current uptake, this shows the different cohorts across, and the scale at the bottom is from 1st of February across to 31st of March. So you've got daily data essentially shown on that chart. What you can see is very good high levels of uptake, so above 90% in the 75 to 79s and the 80 pluses. You can see from the dotted black line, there's what looks like a dip. That's actually a point in time at which the number of people identified as clinically extremely vulnerable went up by the inclusion of using a different algorithm to identify people who weren't previously identified as at risk. So what that's actually showing is a change in the denominator, but an ongoing upward trend. And then you can see obviously the more recent people invited. Obviously at this stage a lower uptake, but similarly a very strong and climbing uptake. So we're really pretty happy about that, to be honest. That's the next slide shows this in a slightly different way. So it breaks it down age cohort by age cohort, with first doses at the top and second doses at the bottom. And again, you can see there quite nicely that particularly for those cohorts who've been receiving invitations for longer, uptake rates are really very high and pretty equivalent across the 3 CCG areas within Herts and West Essex. We've over the last couple of weeks in particular been able to start to get local data on ethnicity variation, again across the 3 CCG areas. And that shows a sort of a more varied pattern. If I sort of pull some of the strands out for you, sort of roughly in the middle, you can see British uptake, and you can see that, for example, Indian or British Indian uptake, which is just towards the right hand side slightly, show very similar levels of uptake. We have other groups, for example, the third set of columns in any other black background, and the last set of columns on the right, white and black Caribbean, much lower rates of uptake. So it's not it's a very nuanced picture, I think, in terms of ethnicity variation of vaccine uptake, and we are doing a lot across all 3 areas to ensure that that where there is lower uptake, that we are tailoring the vaccination programme, tailoring the messages and communications with those communities to help address any issues of concern leading to vaccine hesitancy, and we'll probably pick that up a little bit, I guess, in questions as well. This is just another way of sort of, again, looking at overall uptake. This is in terms of those patients, whether they've been vaccinated through a primary care setting or through an agenda, through a mass vaccination site. This is tracking them back to which primary care area they come from. And again, I think the important thing here is to recognise that there is very little variation in terms of uptake, realistically, and often where uptake is slightly lower, it reflects lower supply of vaccine rather than lack of capacity to deliver. In terms of care homes, we flagged that this was the top priority, care home residents and staff. This is the pattern for Hertfordshire care homes, showing, and you can see this is daily data that is refreshed very much in real time, tracking how many in total residents had been vaccinated up to the day before, and how many were estimated to be left to achieve 100% uptake. Clearly, this is a bit of a moving target because the population of people living in care homes is not a static one. So it practically will be impossible to ever report 100% because people are leaving and joining the whole time. But the main thing, I think, to take very positive messages from is that it's very close to 92% of people who have been vaccinated, and that there is very precise tracking of those individuals in care homes with those individuals where repeat visits are being made, and usually because vaccination has had to be delayed slightly due to outbreaks or patients who had recently been tested as positive. That's the same slide showing care homes in the West Essex area, and obviously particularly around the East Herts area. There will be some fluidity of movement across those boundaries. So very slightly lower rates, but again, very strong overall coverage and very precise tracking of work still to be done. We also track how well we're doing with vaccinating our own staff across the main provider organisations based locally, with uptake rates between 70 and high 80%. And we also look at the proportion of ethnic background staff that have also taken up the offer of a vaccine. And whilst there is a small variance in all of our trusts, in the main, it is actually a very small variance. And there's ongoing work, including within the CCGs, to offer additional information and advice and support to allow people who have any concerns to come forward and get up-to-date, accurate information. And again, that continues. So where are we kind of at the moment, and sort of particularly looking at, was, as I've sort of touched on coming through, we're really keen that we do not, through vaccination, do anything other than improve action on health inequality, and therefore working particularly with the local vaccine cell and with the local primary care networks to identify and specifically target those groups who may otherwise be reluctant to come forwards proactively. So, for example, a lot of work has been done over the last couple of weeks to go out with vaccine to known traveller communities in the St Albans part of the patch and offer vaccination. That's actually been very successful and very well received. Similarly, outreach work into homeless populations and shelters. We're very proud of the fact that across Herts and West Essex we've achieved extremely high vaccination rates for those people who have learning disabilities, partly because we saw them as a special category and started work early on delivering those vaccines and delivering vaccines in a way that was acceptable to people who particularly may struggle to understand the requirements and the pros and cons of vaccination. So that work will continue and is continuing and the fact that we've got a kind of a national timetable doesn't mean that we kind of stop when that cohort is sort of no longer the priority cohort. We continue to do the mop-up work and further work to increase uptake in all of the groups. So I wasn't going to sort of suggest we looked at any more of the data, but I just thought it would be helpful for the committee to have that up-to-date information alongside the written structural information that you've already received. So I will pause at that point, Chair.
Thank you, Jane. And obviously we will share these slides with all the members of the committee. I have to say, I did notice that one or two of them came up with confidential. They're in the public domain now, so they're no longer confidential. So I hope you're comfortable with that. Or if you're not, well, there we are. That's the way it goes. But I mean, you know, we understand the reason for that. So we've got quite a few people that would want to ask you questions. So if I go down the list, right, we'll start off. I think if we do this in chunks of 3, it might be helpful. So if we take sort of 3 questions, so if you can, or if we get a very complicated question that's got 3 parts to it, we'll do with it there. Right. So the first one off, and I hope I've got all these in the right order, and I'm not 100% sure because they're jumping up and down on my screen, but the first one I've got is Dave Hewitt, and then I've got Dee Hart. So Dave.
Thank you, Chairman, and thank you, Jane, for that extremely comprehensive and easy to understand report. One thing you mentioned upon briefly was the fact that there have been problems at time to time obtaining supplies of the vaccine. How much of a problem has that been? How many doses have we missed out on? I assume that we're still on target, or the government target, to vaccinate as many people as possible. Thank you.
Do you want to answer that quickly? Because it's a fairly short one, I think.
Thanks, James. Yeah, so nationally, the supply of vaccine, particularly over the last month or so, has been below our capacity to deliver vaccine. So it's not specifically a Herts and West Essex issue. It's been a more general issue. And essentially what we've got is, roughly speaking, double the capacity to deliver vaccines than we've been receiving. Now that supply from this week forwards, we're being told is greatly increased, what we should be able to do is effectively double the rate at which we're vaccinating people, and that's obviously going to be important because we're starting now to do more and more of the second doses as well.
Okay,
Quick-
Chris.
Quick
Sorry.
supplementary, Chairman. I read in the paper that drive-through vaccinations greatly increase the number of people getting the vaccination. Are there any plans in Hertfordshire or Essex, for that matter, to do drive-through vaccination? Thank you, Chair.
Do you want me to pick that up, Chair?
Yeah, quickly, yeah.
Yeah, so we've already done some drive-through quite successfully. For example, Batchwood in St Albans did one in the snow, which for clinically extremely vulnerable people, so they didn't even have to leave their cars, they just stuck their arm out.
Right, we've got Sue and then Chris.
Thank you, Chair. I just wanted to touch briefly on, I think you referred to it as mopping up, but the process of reaching hard to reach elderly residents. One lady that was brought to my attention in Letchworth was suffering with dementia, and she was missed in trying to contact her to have a home visit to administer the vaccine. So I just wondered, what are the procedures, whether people are followed up with home visits, letters, how does that happen so that we don't miss people from an ethnic background? So
as I've sort of outlined in the paper, where we only know if people are housebound or in those circumstances if they're already known to their GP or through district nursing to be in that situation. So there will always be a small number we're at risk of not knowing about if they have only just sort of come into that category. Essentially, what we did right the way through February was, and it is a slower process by its nature to go around to people's homes and deliver vaccines. We did that proactively across the patch, and when we got to around about the second half of February, then suggested that if people thought that they should have been visited and hadn't, that at that point they made themselves known, because had we done it earlier, the risk is there'd be lots of people ringing up that were already known and just vaccine being scheduled in the next couple of days. But certainly the advice that I would give is that if people are still in the situation where they are housebound or with significant illnesses and no one has made contact with them, they should ring their practice at this stage.
Okay. Thank you, Jane. I made a mistake in my list there. I called Chris out. In fact, it's D before Chris. So Chris is after D. Sorry about that, Chris. D, over to you.
Thank you, Chairman. My quick question is, I'd like to thank NHS staff and volunteers for what they're doing in the vaccination centres. It's the rollout's been fantastic. I've got one very small query. Where my particular, I'm not being parochial here, Chairman, where my division is, it borders the London Borough of Enfield, and I've noticed a number of my residents have been sent to vaccination sites in the London Borough of Enfield. Will they be captured in the numbers for Hertfordshire or not?
Yeah, so two points to explain that, Dee. People who get a letter from the national system go onto the national booking system and they can select where they want to go, and many people we know will select not just where they want to go but a time. You know, the sooner I get it the better. I might be prepared to go a bit further in order to get one this week rather than next week, so that, which is absolutely fine. However, as I'd shown in one of the slides, we get the data and track it back to the practice with which the patient is actually registered, so we still get that information and know about the coverage for all of our residents, and that would be true even if they were being vaccinated, you know, in Cambridge or Scotland or whatever. Not that they should be travelling, heaven forfend, but that, yeah, so the data is accurate.
Can I ask a supplementary, please? Yeah. If a resident has had their first vaccination within Hertfordshire and they move out of Hertfordshire to another region, would they have to come back to Hertfordshire to have the second part of the vaccination?
Not in the main, but it may be slightly complicated depending on exactly where they got the vaccination. So if they've been through the national booking system then they will have been able to have booked a second vaccine for 11 weeks, 12 weeks hence. If they need to then change that, they can just go back into the system and change where they're going. If you've been called through your primary care network, then if your GP doesn't know that you have moved, you will be called back there. But at that point, if you explain that you've moved, actually the arrangements can be made for you not to have to travel. But it won't, if the address hasn't been updated on the system, then there's a small chance of someone being invited over a distance, but it's all can be remedied at the time.
Okay, thank you, Jane. Thank you, Chairman.
Thank you, Chris. Over to you.
Yeah, thank you, Chair, and just echo the appreciation of NHS staff and volunteers, and indeed in some cases councils who have made all of this work in their varying degrees. And continue to do so. Jane is aware of my reservations about the Alban Arena as a regional vaccination centre, given the overcapacity already in the St Albans district. The talk of having an uptick in supply has been around a while. So are you able to give any assurances on two grounds? One is that the new regional facility in Alban Arena won't undermine the existing facilities run by the PCNs and one pharmacy, and are you able to give assurances that patients will not get confused? I mean, I indirectly had the same experience as Dee in relation to someone who was close to me who was offered Pinner as a place to go. Pinner's a nice place, but it's not one I go to often, and there is confusion if you go online at certain points, and I'm worried about that confusion continuing.
Yeah, so to take the two points, Chris, the vaccine supply issue is not that vaccine is being given preferentially down one route or another. The issue we've had over recent weeks has just been less vaccine than we needed. And I have literally colleagues in a parallel meeting at the moment with the regional vaccination team who should be getting confirmation of not just that which vaccine we know that we're getting this week, but over the next 2 weeks as well, because they're now giving us a longer lead time, which makes it much easier, particularly for primary care networks, to plan and schedule their vaccinations. In terms of can I guarantee that people don't get confused, I can tell you that we do a lot around the comms to try and minimise the risk of that, but I couldn't guarantee that people will always find the fact that there are essentially two parallel systems running itself just a bit confusing. I understand that as the rollout continues to lower age ranges over the summer, that it looks like it's going to be possible for all vaccination offers to be bookable through the national system, i.e. you could book into your own practice network, which you can't do directly at the moment. So I think it's likely to be improving, but I do absolutely understand that it's not an easy thing for people to get their head around at the moment, this difference between national and local.
Chris, is that anything else on that, or do you want to come back, or are you happy with that response?
It's just the detail point as to whether there's a danger that the Alban Arena might undermine existing provision, and that has been my fear for some time.
But I think Jane has taken that on board.
It's review on that. Yeah. Okay.
I think we'll just have to see how we'll watch and see how it goes, Chris. And if we think it's causing problems, then we will speak again to regional colleagues. But this has been commissioned as part of we've fed in our views around local capacity. As you know, you're right, we have more capacity in St Albans than we think is needed, and we would have preferred, all things being equal, to have maybe had a bit more capacity somewhere else where we have a little bit more concern. But we'll have to stay very close to it and amend, seek permission to amend if that plays through.
Thank you. We now move on. We now got Margaret and then Roma. Margaret.
Thank you, Chair. Actually, Sue, I think, has covered one of my questions, which was to do with the housebound, and it was a BAME lady that I raised with you about a month ago, I think it was. And And I was just going to say the need for the elderly with dementia to have an advocate who has to phone the GP to alert if they haven't been vaccinated, and that obviously the advocates need to be as aware as somebody with dementia who wouldn't pick up the telephone. That was, but I think I actually was going to ask Sue. I've been trying to chase up to make sure that that lady really has been vaccinated now. The other thing I just noticed in your statistics, and I might need that little the chart back, BAME staff in both West Herts and East Herts hospitals appeared to be lower than in other places, 72%. And then I looked at the percentage of BAME staff within those places that were at about 73%, and I was just going to ask you if you had any special programs that you were trying to encourage BME staff to come forward, or whether it was because they'd had COVID, or whether it was why they appeared to be at a lower rate among our staff in the NHS. That did worry me. And SMI, that was at 49%. Yeah.
So if I take staff and ethnicity first, Margaret. So
Yep.
What we're seeing amongst staff is broadly what we're seeing amongst the population as a whole in the same chart, or another chart that I put up. There are clearly different levels of enthusiasm or reticence in particular communities. What we're trying to do is give some very clear and positive messages about vaccination to staff and to communities, and using a variety of routes to do that. For example, we held a staff webinar last week at which 4 different GPs from 4 of the ethnic minority backgrounds with lower uptakes talked about their experiences of vaccination, about some of the reservations that they've heard in their own communities, and about the factual basis that would refute those sorts of reservations. So that's just, it's an example of trying to continue a dialogue with people, recognise that where there are concerns, our best strategy is to allow people to voice them and help us to address them, rather than to sort of to impose. But we're also, if I'm honest, doing a sort of a dripping stone on a dripping tap on a stone sort of approach, which is trying to wear away concern rather than to confront it. So we're not stopping encouraging staff to come forwards, and that's true across the CCGs and across all of our local providers.
And I was just going to say today's news probably doesn't help, which does remind me of Andrew
Wakefield. Yes,
Wakefield and MMR.
Yeah.
The clots that might be arising from AstraZeneca when I guess the sheer numbers of people being vaccinated, some of them will obviously have clots and be at a risk to thrombosis, as they would be in normal life. I just wondered whether you were going to get a message out about that.
So before I come to that, if you asked the second point about SMI uptake.
Yes, thank you.
So you're right, SMI uptake at the moment is lagging, and that is partly because of the need to take vaccine often to patients, and to ensure that patients are able to give consent, or an advocate can give consent, and so it's just a more time-consuming process. But again, I wouldn't want anyone to think that it's a lack of interest in those individuals. It's just having to tailor the delivery of the programme. Clearly, these are not individuals who can be easily transported to vaccine centres. So that is part of that. In terms of the current coverage around Europe, I think the sensible strategy that we will all be adopting. I believe that the European Medicines Agency are due to make a recommendation tomorrow or Thursday. think Margaret and I could wax lyrical for hours on the statistical basis of this, but I'm not sure that anyone would want to follow us. The message I would want to put out at the moment is very clearly that these are rare events in a very large population, and the most plausible explanation is sheer chance of two things happening in the same time frame that are not connected. But I think we should. We've got the biggest rollout of AstraZeneca vaccine in the UK compared to any country, and this is not a pattern of adverse events that we have seen at all in millions and millions of doses being delivered. I'll leave it there, Margaret.
Thank you, Jane, very much for that very clear message to ourselves here in Hertfordshire and the rest of the country as well. Now we move on as well. We've now got Roma and then Fiona Guest. So Roma, over to you.
Thank you, Seamus. If I could make an observation and then a question, and I probably should have declared an interest through my work at Carers in Hertfordshire. I've been very close to the programme development around vaccination for people with learning disabilities, for unpaid family carers, and now for people with severe mental illness. And I wanted to comment that I think for people with learning disabilities, it's been the most fantastic collaboration. I think the county nurses have worked with the PCNs. I think the reasonable adjustments that have been put in place, and that we've achieved a 79% vaccination level within probably about 3 or 4 weeks of the programme rolling out is fantastic. And I really would like to thank all the people who have been involved in that, and particularly the officers of the county council who have made themselves available to come out and talk to families, talk to people with learning disabilities and explain the practice. So I really think it's been fantastic. In terms of severe mental illness, that programme has only just begun. The group started meeting about 2 weeks ago. People with severe mental illness are within the 6th priority category that's just rolling out now. But my question really was about how soon will the vaccination programme facilitate a kinder, more compassionate programme around visiting in care homes, because we were promised by the Prime Minister that visiting into care homes would open up on the 8th of March. It is still incredibly restrictive, and families are still very distressed by their inability to have regular visits or visits without being gloved and masked and aproned up when they have had the first vaccination and the person in the care home has had the first vaccination. When they come for under a second vaccination, is there any hope that we can see a kinder approach here? Because I'm afraid people at the moment are very, very disappointed with what looked like good news, but which actually is still extremely restrictive. Thank you, Chair.
Jane, a difficult one, but one I'm sure you will appreciate needs to be answered.
No, absolutely. So I will give the best answer I can, but I'm also aware that a lot of the work that is taking place on the specifics of this is actually being led by council officers and not by health. But if I sort of take it from a vaccination point of view, what we know about the vaccination is that it reduces the rate of serious COVID infection and reduces the risk of death. What we don't know yet is the extent to which it impacts directly on transmissibility of infection. And from what we can see from the early data, it's certainly having a positive impact on that spread, but that's different from being confident that it prevents spread in any sort of high level way. So I think the first thing to say is whilst there is continuing uncertainty, it is understandable, albeit not desirable in the social and emotional sense, that infection control precautions are maintained. We would not want, having come so far and done so well to protect some of our most vulnerable, to lose those gains. We don't know. So we know that first vaccination gives most people a significant level of cover. We know that second vaccination will increase that. We will still not know whether, particularly amongst older people who are whose immune systems are usually less good at responding to infections, whether they fully get the same benefit you might get in a younger patient. So there's still a lot of uncertainty, I suppose, Roma, is what I'm trying to draw out, and I think it's because of that the relaxation of the very stringent restrictions around visiting are moving at a very, very small and measured pace at the moment. So I'm not really in a position to say a great deal more.
Roma, did you want to come back at all on that, or are you happy with what you've heard?
I think happy is the wrong word, but I understand what I've heard. I would just put it to the committee that if as many of us as possible could be lobbying for a kinder approach here. I do hear what Dr. Halpin says, but the mental health, the long-term mental health issues for people who have been distressed for 12 months, no real contact with someone who they saw on a daily basis, cannot be understated. And also the impact on the person in the care home who's lacking that stimulus and that comfort. I won't go into, but if as many of us as possible could say we will lobby on behalf of this group, I think that would be very reassuring for them.
I think Roma, it's fair to say that infection control and the way it's being managed is really important to try and restrict down the movement of the COVID around the care homes. So maybe this is a PR exercise that Jane will sort of pick up locally here in Hertfordshire and make sure that there is a kinder and carer way of actually, and a clearer way of explaining why, not just the bare facts, the blunt information that the less contact one has with people in care homes, the less chances of them catching coronavirus. But being a bit more sympathetic about the reasons why that is the case, and I think it could be a PR exercise here, Jane, that you might be able to help us out with. And I think, does that help at all, Roma? No, she's not there.
Yes, thank you, Chair.
Okay, thank you. I think it's a very important point. I tell you, it's a human point, and I think that's what we're talking about here. We're talking about human people's lives, and you can understand. We can all understand the problem here, and we'll move on. I've got Fiona Guest now, and I should say before inviting Fiona to speak, congratulations, Fiona. I think you're the only one of us councillors that gives injections out and does the vaccination for the people of Hertfordshire. So well done for you for getting yourself qualified and helping out with the programme. Over to you, Fiona.
Thank you, Chairman. I've been vaccinating in Buckinghamshire.
Ah, well, I'll take it all back.
That has the advantage of no potential conflict of interest.
Ah, right. Yeah. Okay.
Question I would like to ask, it's about notification of healthcare professionals out in the community. Because in community pharmacy, not just pharmacists, but the support staff, technicians, dispensers, counter assistants and delivery drivers have been vaccinated too. So for the other community professionals, for the optometrists, for the dentists, and the letters being sent out, is it being made clear that all the staff, not just the optometrist or the dentist, will be entitled to vaccinations?
I believe so, Fiona. I could, but I would want to go and just double check that. We have done considerable work to identify all of those healthcare staff who we can find the ones that are on the NHS payroll reasonably easily. It's the rest of the healthcare workforce who are working in private practice, in community settings, high street settings, and so on. But if you could leave that with me, I will go and double check.
Thank you.
Thank you for that, Jane. I've got Richard Roberts next.
Thank you, Chairman. I just wanted to come back and thank Roma for her comments about how we've all worked together, particularly around the vaccination programme, but also to support those with LD to get into the vaccination programme as soon as possible. And then just a comment about visiting. There was an ask, is anybody advocating on behalf of our residents in care homes in terms of a kinder and a more caring approach? And one of those people is me. And we've worked closely with Carers in Hearts and with AGK in Hertfordshire, with the Alzheimer's Society over a number of months now, meeting very regularly to ensure that we have the best possible communication over visiting and to open up as quickly as possible. And before the government guidance came out, some 3 weeks before the government guidance came out, we were working with HCPA, which is the Hertfordshire Care Providers Association, which we support at the County Council. We were working with them to make sure the message was getting out into care homes to open up as much as possible to allow contact during visiting. This is what Roma has asked for, and this is what we have promoted. Your comments, Chairman, about the need, and from Jane as well, about infection control are just as apposite. The Kent variant is still out there. It is still live. We have still got a pandemic on, and that, particularly for our private providers, is really still a live issue. But just to say that we have all of those organisations, including the County Council, including with our health colleagues, are pushing to have as much humane and caring contact as possible. Thank you so much, Chairman.
Thank you for those kind words there, and it's very human words. Again, because that's what this is about. This is about managing it. Right, now we've now got Ron Tyndall, and then the last one I've got is Steve Palmer, who's from Health Watch. So Ron, over to you next.
Thank you very much. Jane, you'll be very pleased to hear this is a thank you, and which I'd like to be passed on to Maxted Road Centre, because I had a very, very concerned resident ring me up a short while ago who had a daughter whose mobility was impaired. I managed to get clarification of the way in which she would be welcomed, and I got a very good thank you text from the lady the other day to say that she attended, the volunteers and everybody was very welcome. She was told where to park. A doctor came out and gave her the facts, and it was all over in 15 minutes, and everybody was happy. So I'm not sure whether everybody knows this, so I thought I'd tell that story, because quite simply, if anybody with restricted mobility is concerned, the County Council volunteers and the NHS together have got a system that actually deals with everybody in a very compassionate and very efficient and a very successful way. And so I think it's all good news. Thanks, as I say, to the local authorities and the NHS combined.
Jane, did you want to add anything on to that?
No, just to say that thank you for Ron. It is really it's really good to get positive feedback, because being honest, a lot of the time in the NHS, the feedback we get through this sort of meeting, not individuals, often is highlighting the bits we could do better. So it's really heartening to get such positive feedback. The only bit I would add is that type of feedback we've heard now in relation to so many of our vaccine centres, and I think one of the things that for me has been a strange positive out of all of this is there's been a real sense of community pulling together across professionals, volunteers, health staff, council staff, and others. It's really felt like a joint endeavour, and I think communities have really appreciated that.
Thanks, Jane. And our last person that wants to say something this morning, anyway, on this subject is Steve Palmer. And Steve is chairman of Health Watch here in Hertfordshire.
Yeah, thank you very much, Chair. I thought the committee might like to know, we've been running a couple of surveys. One is aimed at what the patient's actual experience of the actual vaccination centres and actually getting the vaccine is. And I have to say that has been extraordinarily positive. I think everybody's comments there has recognised and said that already, so I won't really go into that. But we've also been running another survey, which is about asking people why they haven't been taking up the vaccine, and although it's been running for about 3 weeks now, we're getting some data in which I thought I'd just report some of the issues that are raised from that. There are a couple of specifics. There are a number of people, men and women, who've been raising concerns about perceived effects of the vaccine on fertility, and so there's a number of people actually been raised saying we don't want the vaccination because of concerns about fertility. There's a second group, which is, I mean, I suppose it's a more general one. It comes on from the discussions that's happening in Europe over the AstraZeneca vaccine, which is just a general concern about it's not being tested, it's too soon, we want to wait and see. So there's a group that are concerned about that. And the third group, which we're getting quite a number of people, which are mainly BAME groups, which is, I suppose, it's not so much vaccine scepticism, it's more general scepticism about the state and the businesses involved, and a reluctance to sort of being seen and almost being experimented upon. And I'm just thinking, I think the importance about this is that clearly how you actually get to these groups. Well, you need to get your communication sorted out and aim specifically at these groups. So although this is a work in progress, I thought the committee might be quite interesting to see that there are quite a number of different reasons that people are saying why they're not having the injection.
Jane, before you jump in and answer that point, I think it's fair, Steve, if you actually share some of your results of surveys with Jane. You can do it through Natalie, and she'll pass it on, because I think that will help her. Right, over to you, Jane, now to give us your view on those particular issues.
Yeah, no, thank you, Steve. I mean, some of those concerns are very similar to ones that we've picked up, for example, in the sort of Q&A sessions that we've done with NHS staff, and there are some very good information sources on the Healthier Together website that actually directly address those. So there's we'll make sure that we send the link through again to Natalie, so that can be circulated with follow-up materials at the end of today. But yeah, with the fertility issue, there is absolutely no evidence that this vaccine, or indeed any vaccine, interferes with fertility. So that one's been quite an interesting one. The other one, again, we have heard not so much through staff, but through BME group feedback is this sense of state interference, and particularly not so much in Hertfordshire, but heard from colleagues in Luton and Peterborough and so on, that people not wanting to come forwards because their immigration status may not be as it should be, and that potentially then feeding some of the ongoing outbreaks that we've seen. So yeah, it's a very complicated picture, and needs very nuanced messaging and very tailored outreach.
Yeah, I think you've actually said something there regarding the immigration side of things. I mean, I don't know how many people are in the country that shouldn't be in the country. I don't know if anyone knows, but I mean, how do you manage that? I mean, how do you get them to come forward, and how and is there any repercussions? Can you say for if there's any repercussions for those who shouldn't be in this country in relation to having this vaccination?
Yeah, so in terms of the repercussions, no, we want to vaccinate people. All of the people involved in this programme want to deliver the maximum amount of vaccine and reduce the harm that COVID does. They will not be asking. If people don't have an NHS number, they can still get a vaccine. That is not a requirement. I think the issue is in terms of how do you do that. It's really about taking vaccine to places, to workplaces, and for example, or into community settings, and encouraging people to come forwards. Again, as I've sort of touched on over the course of this presentation, as vaccine supply becomes less of a constraint, it will be easier to do more of that. At the moment, we're having to do this very age structured profile. If we have got much higher levels of vaccination and we're moving into the younger age group, I think we'll be evolving the models of delivery to do far more outreach or mass vaccine, like I say, in a workplace setting or a particular community setting, which is a way of reaching all sorts of people who are otherwise reluctant to come forward.
Thank you, Jane. And that's all the questions we've got for yourself on this particular subject. It's fair to say that this has been a great success, not only nationally, but locally. Nationally, there's been 24,400,000 doses given out, and there's been over 1.6 million second doses given out, which is an incredible amount. And we've now seen the figures, the relation to the 7-day figures dropping down, and also the mortality rates dropping down significantly. So I think on behalf of all the residents of Hertfordshire, we'd like to thank you for everything you've done on this. You've done a brilliant job. Keep going. And, you know, there's a bit of PR that's needed here and there, but I'm sure you're picking up what we're saying, and well done you. So a big congratulations. Now, if we now move on, we'd have to, let me see now, do we need to take a vote? Where the recommendations are to vote via chat, yes. So we've got recommended the committee is invited to note the contents of this report, and the committee raises questions where you've raised the questions in relation to the vaccine programme. So can I ask you to agree to note the report in the chat box? Thank you. Okay, are we there?
Majority agreed, Chairman.
Ah, brilliant, brilliant, brilliant. Well, thank you again, Jane. You've done a fantastic job. Keep it up. You're protecting the residents of Hertfordshire and the country. So well done. It's a great success for the NHS, no doubt about it. Now, we did say at the beginning, I did say at the beginning, I'm going to also alter the agenda slightly. I'm going to take Jane's next item, which is agenda item 5 next, before we move on. So, Jane, if I invite you to do your presentation or whatever in relation to the integrated care system response to COVID to February 21. I understand this isn't a great big long one, but anyway, over to you, and let's hear it.
Yeah, so I'm sure the committee would be pleased to have a much shorter report. Interesting, though, I think it was to go through the vaccination side of things. The second shorter report is just to give a quick summary of the response to COVID illness over essentially the last 3 months, December, January, February. During which time we saw a very noticeable rise in infections, leading inexorably to hospital admissions and sadly to increased deaths again. This has clearly had a very significant impact in a number of ways, for particularly through from about mid-December to mid-February. The vast majority of work being done in our hospitals again was dealing with very seriously ill COVID patients, and that has had again knock-on consequences for the ability to treat other patients in all sorts of ways. One, that we didn't at times have as many staff because staff were themselves sick or self-isolating due to contact with infected people. Equally, we've had parts of the hospital which have had to be turned into additional critical care capacity, and therefore were not available for other purposes. Having said all of that, compared to the first wave of infection last spring, we were able to keep far more services running in parallel, having learnt how we could tailor things in a different way, and had more contingency sort of plans in place. So, for example, we have continued to treat patients with cancer. Cancer surgery has continued maybe not quite at the same rate, but materially seeing and treating patients with urgent clinical needs in real time. So I think there's quite a lot to be positive about there. I think we have seen ongoing innovation in other services. Primary care has continued to operate, albeit maintaining a triage first system. Our ambulance services have been able to do more of what they call hear and treat. So actually effectively provided advice and direction rather than turn up. So right the way across the healthcare environment, there has been, let's say, innovation in response to this, as well as the very real challenges. There are, however, certain groups that and have sort of flagged, for example, people with severe learning disabilities or autism, where and it sort of plays back to part of Roma's concern around care homes, where people just are deconditioning, are losing skills or abilities that they have because of the restrictions in sort of rehabilitation services and support and engagement services. So I won't sort of dwell on it, Chair, but I just thought, it's a couple of last messages probably to leave people with. I think increasingly when we're planning within the NHS around how we restore services, we're increasingly looking at how we redesign them at the same time. I think clearly there will be backlogs in certain areas to be caught up with, but rather than try and put things back to where they were at the beginning of all of this more than a year ago, I think it's us looking at how we might see patients in a different way that gives them care sooner and faster, but through a different type of pathway. I think the other bit I would want to raise with the committee is all of our provider organisations are really increasingly worried about how staff who now have been working pretty relentlessly for a year and without much in the way of a break, as has people in all sorts of different professions and industries, but the increased demands on staff to at the same time as recover themselves from that to undertake additional work doesn't feel very humane, and balancing that staff well-being with patient safety and patient care is going to be a difficult one to get completely right, and we are concerned if we don't address it openly and proactively, we will lose more staff who will choose to reduce their hours, retire early, getting a lot of informal sense that quite a lot of particularly our older staff have been kind of hanging on because they didn't want to let people down and wanted to get through this pandemic, but are seriously considering that they don't want to go on forever doing this. So I guess just a plea to sort of bear with us and work with us as we try and get that balance right in the coming months.
Yeah, I think before I bring Sue and Roma in, I think it's fair to say, and a big thank you from all the residents to all the ex-staff that have come back to actually help out during this difficult time, because they've come back, the doctors, the nurses, whoever they are, the health workers that have retired and moved on from the health service, but they've decided to come back to help out. I think we should recognise that as well, that particular point as well. So we've got Fiona, Roma, and then Fiona Guest. So, sorry, no, we haven't. We've got Sue and then Roma. Sorry, I'm brainstorming here. We've got Sue. You're first off, Sue. Where are you, Sue?
Sorry, I think that's a legacy hand. I do apologise.
Oh, no problem then. Well, we've got Roma. That's brilliant. That moves us on. They're nearly right. I'm nearly back on track again. So I've got Roma and then Fiona Guest. Roma. Back on track again. So I've got Roma and then Fiona Guest. Roma.
Thank you, Chair. Yes, I think we all do have to acknowledge the huge pressure that a lot of NHS staff and social care staff have been under. And you sort of keep going and keep going and keep going until you see an end in sight, and then often you just fall over, don't you? So that is a very big issue. But I think there are those other concerns, like the loss of function among certain groups during the last year, but also the backlog of people waiting for other treatments. Perhaps not that urgent, but planned treatments. Is there any feel for the volume of that? I mean, we've heard quite a lot about the volume of people who will be suffering a long-term mental health impact, but what about people who've been waiting for diagnosis, for testing, whatever, or for non-urgent but nonetheless quite important treatments? Is there a feel for the size of that?
Yeah, so as you would expect, we've continued to work on that in parallel with the COVID response and the rollout of the vaccination. We were at the forefront of developing a clinical prioritisation approach, particularly for patients awaiting surgery, that has been taken up and used regionally to ensure that patients with the most urgent need are treated soonest, and also to look about how we potentially offer patients the opportunity to get that treatment in the first place that is able to offer it, as opposed to necessarily the hospital that they thought they were going to. Again, done with patients, not to patients. We have been working on how we open up access to some of the less acute services in a way that allows, rather than patients waiting in a queue for someone to permit them in through a particular treatment doorway, how we, where appropriate, make those services more directly available to reduce the waiting times. We're also doing quite intensive work on forecasting what we think mental health needs are for our population, so that we can be putting additional services in, because we see that as something that is rising now, but will continue to have an impact over quite a prolonged period of time. So in other words, if we just count today's backlog, we're probably missing the future demand. So a lot of work going on, Roma, but different numbers in terms of different parts of treatment pathways. And then the third sort of specific bit we're also looking at is where we think we are missing patients. So services that would typically have seen higher rates of referral and have seen much lower rates of referral, understanding what that might mean. So one example is we've seen lower rates of referral of patients into assessment clinics for dementia. That may well indicate that the more clunky nature of going through triage first at the moment is more of a barrier where there are cognitive problems than for other areas. There may be other explanations. So again, we're trying to look into those areas. The last bit, and it's back to the having been able to keep more services running, we have continued to run materially significant higher amounts of those core diagnostic services, and we'll be focusing, so things like endoscopy as part of a diagnosis pathway for many types of cancer or other significant illness. So we do have a backlog, but it's much less than we had coming out of the spring, and focus work to catch up on that as a priority.
Thank you, Jane. Fiona Guest, over to you.
Thank you, Chairman. As looking at the papers on page 30, item 2.5, I'd like some clarification, because it states that NHS 111 first went live at the start of December, so reducing the need for unheralded patient attendance at emergency departments. But could you clarify, please, because NHS 111 had been running for some time before then?
Sorry, that's one of those lovely punctuation errors. If it was a capital F, it would have been clearer. So my apologies. There's an approach called NHS 111 First, which went live nationally at the start of December, and that is encouraging a number of things, encouraging patients to use NHS 111 rather than simply turn up at an emergency department, but also enabling the existing 111 service to be able to direct patients in different ways if they determine that their best treatment option possibly isn't an emergency department, or indeed to pre-book them a time slot at an emergency department if they do need to go, but it's not a sort of a blue light emergency. So it's quite a complex programme, but my apologies that I gave the wrong impression with the lack of the capital.
Thank you for that, Jane.
That I can assure that NHS 111 refers to community pharmacies. The system does work.
Good.
Yeah, I think it's fair to say, Jane, that what we're looking for here, and what we're trying to avoid, I suppose, is things falling through the cracks. When we look at things like the diabetes services potentially across the patch they're still there, but they haven't been running as they shouldn't, as they normally do. Things like regular eye screening, things like this, and I know that myself because I have my eyes screened regularly for various different things, and that wasn't happening. So I suppose the most important thing is that we've got to have the confidence that you guys are going to be picking up everything to make sure there's nothing falling through the cracks. And from what I've heard today, I believe we have that confidence. So I'm going to ask everyone, can we note the report in the chat box, please? Oh, we've got to agree it. Yeah. Agree it. Do we note it? Agree to note it.
Majority agreed, Chairman.
Thank you. And what I'm going to now do is that item is noted. And thank you very much, Jane, for all the input today. What I'm going to suggest now is that we have a short comfort break. Can we say 10 minutes or 9 minutes? I'm gonna be a bit fussy, isn't it? If I say it's 11 minutes past now, and then if we come back in 9 minutes time, that will work quite nicely with our timetable. We've actually done the big items on the agenda, so as we move forward, the rest of them will be a bit shorter. So in time length, not in quantity or depth or whatever. So can I just ask that the meeting is paused at this moment and we come back then in 9 minutes time? Okay. Thank you very much, and welcome back after our short break there. We now move back to the agenda. If you remember, we've covered items 3 and 5. So if we go back to 4, which is the Hertfordshire Partnership University NHS Foundation Trust update. We've got Helen. Is Helen with us to present?
No, good morning, Chair. It's myself, Keith Loveman, and my colleague Sandra Brooks, if that's okay.
It's fine. You know, these notes I have in relation to who's speaking is actually done a few weeks in advance, and therefore things change, and we understand that. So over to you, Keith. Over to you.
So, if I may, Chair, we'll just give a very brief update from the report. I'll update on COVID, where we are there, and Sandra's going to say a few words around where we are in terms of operational services and operationally, but we'll do that as quickly as possible to give as much time as we can for any questions. So if I kick off, and I guess I'd start from a sad point of view. Very sadly, the number of service users deaths known to us has risen to 189, and of those, 15 are reportable by the Trust. And you'll see from the report, we're also reporting 2 staff deaths as well, very sadly. More positively, over the last 3 weeks, the number of confirmed and suspected cases for both service users and staff has reduced significantly. And we're currently reporting no inpatient cases for COVID, 10 in the community, and 5 staff cases. So that's a significant change from where we were at earlier in the year. Staff sickness absence is now predominantly non-COVID, but there's still some pressure on staffing levels due to factors such as shielding, etc. But again, improving. Although we've no reported inpatient cases of COVID, we're still continuing to manage 5 official outbreaks, but we're hoping for closure by Public Health England in due course. In terms of vaccinations, I know you've had some discussion about that already this morning. All of our inpatient service users are offered a vaccination. And notably, all older people and learning disability inpatients have received their first vaccination, and a number of them second dose as well. We've also worked very closely with partner organisations, particularly the County Council and the third sector, in relation to service users on the Learning Disability Register. And I think Roma mentioned 79% of all service users have been vaccinated. I dare to contradict her. I think that's now up to 82% now, actually. So I'd like to go with the higher figure if we can. But I think a very positive outcome in terms of joint working across a range of organisations, but also I think to recognise the effort that was made in pushing very strongly nationally for learning disabilities to be properly moved up the priority list for vaccinations, and again that has happened. So that's been very positive. In terms of SMI, we're focusing on care coordinators and staff, very much supporting individuals to access vaccinations and advocating for them to help them to do that. For staff, we're over 85% for all staff, and BAME vaccination uptake is now over 75%. We've seen some very positive work by the BAME staff network in supporting people to access vaccines. But what I would say is that we're looking at more specific targeting in our continued efforts to increase uptake. So BAME coffee mornings, but also inviting pastors, significant others to come in and give specific talks, because within the BAME community, obviously, you have very significant cultures as well within that group of people. I think, though, we're probably saying we're at the point where actually we won't see a significant increase now in those numbers. We may see some additional increase, but I don't think it's going to shift significantly. But our second dose vaccination plans are now all finalised, so we're gearing up for that as well. And I can pass on now to Sandra.
Thank you, Keith. So in terms of operational services, we've got some key operational issues that we're working through. So we continue to have to focus on a really tight management of transfers and admissions and clear risk assessments, because we still have a number of wards that are classed as outbreaks. So that's some piece of work that's ongoing as we do move service users or admit, particularly from the acute wards. A key focus at the moment is for us to enable safe visiting. So that's been really important throughout the pandemic, that we've been able to assess on an individual basis for visitors to be able to come in and see their loved ones, and that continues to be a key priority for us. We have seen bed occupancy, particularly in our adult services, continue to be high at 99% and above. And that does mean that unfortunately we are still having to use out of area beds to support some of those service users, and that continues to be a focus on how we're going to reduce that and bring everybody into our own beds. But that demand on the adult beds has been really consistent throughout. We are experiencing, again, not a new picture, but something that is really quite a big focus at the moment, is around the lack of CAMS specialist beds nationally. So that is still a challenge if we need a specialist bed, particularly eating disorders. Continuing to work with partners, and both nationally and regionally, around that capacity and how we can work differently. We have experienced some specific spikes in some of our services, probably most noticeably our children, young people's eating disorder service and our adult services, where we've seen an increase in CAMS of about 40 to 50% increase in referrals. That is continuing. We've also noticed an under-occupancy in terms of our beds for older people with dementia, and I know that Jane referred earlier to a drop in dementia diagnosis. I think really sadly, that may well be due to some of the high number of deaths we're seeing in our older adult population. But also is I think probably due to families not necessarily seeing some of their elderly relatives and not maybe picking up deterioration in their cognition, etc. So we're obviously really encouraging referrals into our services, and we'll continue to do that and look at how we can work with our primary care colleagues as well to make sure that nobody is missing out on getting a dementia diagnosis. So our focus really going forwards is really thinking about how do we recover our services within the context of COVID. Again, as mentioned by Keith and Jane, a big focus on the recovery of our staff alongside the recovery of service users and carers. And really looking at our planning for increasing demand. Some of the forecasts show that potentially in mental health services we may see up to a 30% increase in demand. So we're working both within the ICS and with other organisations to really look at the modelling of that demand going forwards, and how that may play out, particularly in Hertfordshire, and how we need to respond to that. And critically, we're working on plans both to support our staff and to develop our services. And a big part of that is a focus on transformation. So again, really learning from the last few months, what do we want to take forwards, what's worked well, but actually how do we transform services going forwards. So that's a quick run through of where we're at in terms of our services. I'll hand back to the chair.
Thank you very much, Sandra and Keith. So no, I've got no hands raised. I have a hand raised. I thought Ron, you've saved the day, and then Margaret and Fiona. And Roma. So okay, Ron, you're first off with your comments or questions.
Thanks very much. Thank you for that report. Sandra, I was, and also the previous report, I'm extremely concerned to hear about the CAMS beds still being a challenge, and that referrals are up 30 to 40%. I just wonder, clearly, do you anticipate that this is a long haul process, actually bringing our children back to from the last year of suffering under the lockdowns and the various other schools and the other things, just perhaps if you could expand that a bit, because I think for most of us, this is one of the crucial areas that we need to get right going forward.
Thank you, Ron. So I would say it is I don't think this is going to suddenly change. I think we've got to be planning quite a long way ahead in terms of the impact on children and young people. Yes, the specialist beds do remain a challenge, and I guess we're tackling that in a number of ways. So one way is to look at how we can do things differently to prevent us needing to admit young people. So, for example, what we've done is we've increased the number of beds we're using in our adolescent unit for people with eating disorders. So again, to try and prevent them having to go out of area. We're also looking at our community eating disorders service, and we've increased resources and changed the skill mix again to try and prevent the need for admission. And we've also reviewed the resources into our home treatment team to prevent admission into acute beds. So there's a lot of work going on. We're working across the ICS. We've been working with West Essex on some of the work they've been doing, sharing ideas, different ways of working, very much focus on prevention. And then we're also working collaboratively across the region to look at the beds, specialist beds, and again, how can we develop more models across all areas to prevent admission, but also look at different ways of using the beds, looking at how we can work with those providers differently. So lots happening, and that is all very much based on a longer term approach. And obviously with the schools going back last week, we now need to look at what that's going to do in terms of the impact on demand. Usually we do see peaks and troughs in relation to school terms. We've continued to provide support into schools throughout the pandemic, but we do envisage a change again in terms of that demand as the children return back to school. So it's continuing to model and work through that and work, as I say, very much as a system approach to that demand, and putting more at the front door so that it's easier for young people and families to get into services and for us to assess their needs as quickly as possible.
Thanks. And if I could perhaps ask one sneaky little extra question, could you explain exactly how you're currently working with the County Council and their services to make sure that we have an integrated service across the whole of Hertfordshire, involving everybody working together in the same direction?
So we very much, we have a lot of contact with our county council services. We have specific services that are focused on looked after children, which again is a factor we've seen coming out of the pandemic, that we've seen a higher number of looked after children in our services. So there's a number of things that ongoingly we have a specific service that works with the county council for looked after children. We're working on a business case at the moment to develop an integrated team, health and social care team, to go and support young people in the children's homes. And the new children's homes that have been commissioned for this year, we will start to pilot that approach. So that we're actually looking at a team, as I say, that will have therapy staff and other health staff working alongside social care staff to manage some of the young people with more challenging behaviour in the care home. So continuing that we are part of the CAMHS Director Steering Group and the CAMHS and Children's Wellbeing Board, which is all the organisations across the system. So working in a much more integrated way than I think we've ever done, actually, which is really important.
Thanks very much, Sandra.
Thank you. We've now got Margaret, Fiona, and then Roma. Margaret.
Thank you, Chair. Can you hear me?
Yes, and I do apologise if I've got you in the slight wrong order, because it keeps changing on my screen here in front of me. And at one stage I even had Norma's hand up and it seemed to disappear. I don't understand why, but never mind. Margaret, over to you.
Thank you. So probably Sandra and Keith, I think, but just to clarify that there are some interesting words used in your report. On page 25, paragraph 3.7, just wondered, you said you're developing a programme that will support staff recovery, focusing on paying witness. I'm not sure what that is. And then obviously the others are a bit more self-explanatory. Could you just explain what that is? That's something for clarification. And then, given that we've just heard statistics from Jane Halpin on severe mental illness patients, only 49% of them being vaccinated, and I can really understand that that's a bit tricky actually when people are sectioned, that obviously being vaccinated is voluntary, whereas some treatments are injections, and you don't want to confuse the two. But I was just wondering how you're going to help the severely mentally ill get vaccinated better. And in section 6.2 on page 26, I was quite interested that you've said you're going to maximise access to vaccine and recruit into mental health roles within primary care. I've always been very interested in that, a bit of a champion for that. GPs with special interests in mental illness. So I was just wondering if you could just clarify those particular paragraphs in the report for me.
So perhaps if I kick off with the first bit, and then Sandra can talk a little bit more about seriously mentally ill and access there. Yes, just in terms of paying witness, it's really about giving staff time and space and an opportunity to talk with people or to consider for themselves what's happened over the last year. And we've seen a whole range of emotions and responses from staff, and those things take a bit of time to work through. You know, some staff are extremely traumatized. You know, they've worked on wards where they've been supporting people for a long period of time, and they've seen those people pass away. You know, and that's been very difficult. And we've also had, you know, we've had all of our staff have been working pretty excessive hours for 12 to 15 months now. So paying witness is really just that bit about time and space, whatever that might mean for them, and support psychologically or whatever they need to really think that through and to help them start to think about looking forwards.
So it's like feedback on their own experience, really, is that right?
Yeah,
reports.
Absolutely, but it could be anything, you know, opportunity just to maybe meet with people to talk about what's happened to them and to work that through for themselves.
Okay, that wasn't quite obvious. I just
no, and I think so. It's, you know, it's our head of psychology who's used that term. It's landed very well with staff, and I guess it means different things for different people, but it really is about an opportunity to think about what's happened.
Okay,
it's an important part of the recovery process.
Thank you, Keith. Thank you for that answer. That's really good. It's very clear. Now we've got Fiona Guest and then Roma Mills. Fiona.
Seamus, I think there were a couple of other points that Margaret raised.
Oh, was that?
Sandra and Keith will be able to address.
Okay, go on. Did you want to answer?
Yeah, thanks, Cheryl. I have to answer that. So in terms of SMI and encouraging those service users to get their vaccine, it's very much I'm wanting to work with those service users around looking about any particular anxieties they may have. So we will be encouraging our community staff to discuss that with our service users to try and facilitate them going to vaccination centres or the GPs, whatever is appropriate. Our primary care workers are working with the GPs to identify people that we're particularly concerned about. So we're cross-referencing who we got on our caseload and who's on the GP caseload. So it's that constant support, education. And some of our IAPT workers have also been trained around needle phobia, which is a very specific focus. So again, if we do have somebody who's got a particular phobia, then we can bring in some specific support. So we'll continue to do that. I think the other bit, Margaret, around primary care. So I think, you know, for some time we've been developing primary care. We've had a number of pilots. But we now nationally, you may well have heard of the development where every PCN will have at least one mental health worker assigned to them. So it's a really exciting piece of work. They will be employed by us as the Mental Health Trust, but very much it'll be working with the PCNs to see what type of worker that might be, what will be focused on their area. So we're in contact at the moment with the PCNs, talking through that, looking at what that might do, but really exciting about how we might develop. So we're looking at potentially additional 30 workers in Hertfordshire, which is really good. And I think it's going to make a significant difference to our primary care offer.
Did you say they're funded by the PCN or they are funded by
50% by PCN, 50% by the trust? So we're still working through how that follows, the money follows through with commissioning. But yeah, it's a really exciting piece of work ahead of us around that.
Okay, thank you. I'd be interested to see how that develops and perhaps hearing more, especially because we've had counsellors perhaps in GP surgeries, but then other sorts of people that can get alongside people with mental illness problems. Thank you for enlarging.
Yeah, that's good. Good news. Right, now we move on then. Fiona Guest next, and then Roma.
Thank you, Chairman. Like all good sermons, this has got 3 points. Is page 24, 3.1, the lateral flow testing of staff. Could you clarify whether that's twice a day or twice a week? And the second point is 3.4. That's when the trust work closely with partners in moving residents from a care home with a very high COVID-19 incident numbers at a very short notice. Were the residents who were moved tested first? And the third point is going down here. Yes, on page 26, 4.6, the high number of young people presenting following self-harm. Actually, had numbers increased since the first lockdown commenced?
So perhaps I can certainly answer the first one. I'll have a go at the second point, and then Sandra will pick up the third one. And if anything I've missed anything. So in terms of lateral flow tests, it's twice a week that staff test.
I have to test twice a week.
Yeah, so it's twice a week. In terms of the specific moves around the care home, so it was a joint effort between the County Council with colleagues from the Community Trust and ourselves to support people with learning disabilities for that move, but also our nurse consultant who is responsible around physical health care as well. So all the relevant testing was done. But the key thing was to make sure that they had staffing support, because so many of the staff in the home were off sick, and so it became unviable for them to remain there. So that was the key bit. But all the appropriate testing and infection control measures were taken. Yes, and then I think the third one I'll pass over to Sandra if I can.
Thanks, Keith. So year on year, we are seeing an increase in young people self-harming. So it's gradually gone up, and it's gone up throughout the pandemic. Not massively, it's not a really significant spike, but say year on year, we're seeing that increase. And I think one of the key points is that what we have seen is a high number of young people that have been overdosing. That's a significant factor. So obviously we see a range of self-harm, but what we have seen through the pandemic is young people taking quite excessive amounts of tablets, generally speaking, and that's quite noticeable in the presentations that we've seen.
Thank you.
Oh, we've lost you.
You're mute, Seamus. You're mute.
Oh, sorry about that. We've got Roma next, and then Norma's hand is back up again. So we'll deal with that then. But Roma's first.
Thank you. Thank you very much, Seamus. Just a question of my lack of understanding. In what context, Keith, is a death reportable by the Trust as opposed to being recorded as death? That's one thing. Keith, you were very kindly able to update us on the figures or the percentage of people with learning disability who have been vaccinated. Is the figure of 49% for people with severe mental illness still the right figure, or has that also increased? I'd be interested to know about that. I think the issue about learning disability and the disproportionate number of deaths or the vulnerability you have already referred to, and we know that that group of people are now a priority. But I noticed in 2.4, you said that 20%, if I can say, of your patient list, if that's a way of describing it, 20% of the deaths within your patient list were of people with learning disability. What percentage within your patient or service user list are people with learning disability. I wondered how the actual percentage and the percentage of deaths compared. And just a final comment, I've been quite surprised to discover that the vast majority of people with severe mental illness, well, it's a good thing to find out really, are stable or in recovery. So the vast majority are in the care of their GPs, not of the trust. They're not open to the trust. And I think it's worth saying here that, organisations like Mind in Mid-Hearts are the ones who are stepping up to support, the very many people who come into that category. So I think perhaps that needs to be noted too. But to those specific questions, I don't know if Keith can help me.
Yes, I will. And then if there's any bits I falter on, I'm sure Sandra will step in. So in terms of deaths, the ones that are reportable are individuals who pass away actually on our wards. So we've had 15 inpatients have passed away, but of course, as you can imagine, as people get ill and need hospitalisation, they're transferred across to the acute hospitals, and it's then if they pass away there, then the acute hospitals will report the death of those, and then a number within that are service users who are known to us but reside perhaps in care homes, and if they pass away either in the care home or in the acute trust, we know those individuals, but they haven't passed away on our wards, and therefore those deaths aren't reportable by us directly. In terms of SMI, now I've got to be careful here because I think the number has risen to over 55%, but I don't particularly want to be quoted on that because I couldn't swear to it. But we could probably, outside of here, let you have a more up-to-date figure on that one. I think that would be important. For the number of service users, so I think we've got something like 1,000 individuals with a learning disability on our books, and overall we have about 40 to 50,000 people registered. So quite a small proportion in that sense. But across Hertfordshire, the population who are known to either the county council or HPFT services is about 4,000. The majority of individuals are looked after outside of our organisation, as you quite rightly point out. All deaths for learning disabilities are reportable through the LEADER programme, which is LD Mortality Review, and that's what raised the issues for us and for partners is that that's identified a significant increase, probably twice the amount of deaths for people with a learning disability compared to the same period in the previous 2 years. But those are not solely related to COVID in terms of COVID infection, but they might be due to people not accessing services due to COVID, not having health checks because they're in care homes and that's not happened, etc. So there are a number of reasons, but clearly a disproportionate impact for people with a learning disability. And I couldn't agree with you more. Absolutely, I think we talked earlier about the work around moving people from the care home, and that was very much a joint piece of work across a number of organisations, and you're right to call out people like Mind, absolutely critical in supporting people in terms of COVID, but more generally anyway.
Okay, thank you. Thank you for that. And in relation to the figures, Keith, the figures that you weren't 100% sure about, they could be right, they more likely are. But if they are in any way different, could you send it on to Natalie, and then she can then send it out to the whole committee, because I think we'd all want to see those figures.
Yeah, I'll get a number anyway, Chair, and just make sure that Natalie's got that, and then we can be confident that it's the right number.
Yeah, that's fine. Okay, let me see. So the last one I've got on this section is Norma. Norma, did you want to say something?
Yes, I did. Can you hear me?
We can hear you very well.
Right, this is particularly learning disabilities, autism. And I was just wondering, I know you can now visit one-on-one, but during the actual pandemic, could people with learning disabilities and autism have visitors in a controlled space? Because I met my son who comes under that bracket and I haven't seen them for ages, and he spent the entire time, we were outside, and he spent the entire time crying.
Okay, we mustn't get involved in personal
No,
cases.
I'm not saying
but I
that,
do
Seamus. I'm
understand.
just saying, you know.
Yes, but I do understand what you're doing is you're highlighting this as a potential issue from
Yes.
your own experiences. So over to you, Keith.
Yeah, so what I would say, certainly from HPFT's perspective, we had no blanket restriction on visiting at any time. But as Sandra alluded to earlier, it was all done through specific individual risk assessments. But I'm conscious of what Roma said previously. You know, some of those visits were not in the way that we might like to have been able to enable them in kind of normal circumstances, and we're looking to move back towards that as quickly as possible. I don't know if Sandra's got anything to add around that.
I think that's right, Keith, and I think what we have learned from sort of during the summer, we did look at ways of being able to enable visits outside as well, and we need to learn from that to look at how we do that on a more ongoing basis, because actually that's worked quite well for some people rather than necessarily coming into the ward environment. So it's learning from that, but I think we do really realise how important visiting is for people, for families and their loved ones. Really important.
Thank you, and I should just add further to my comments before that this for those who are watching at home, that this particular committee doesn't get involved in particular casework as such. But we're using this. But what Norma was doing was using her personal experiences to share with so that others can be would know what is happening as well in this instance. But normally we don't get involved in casework. So thank you for Norma for sharing that with us anyway there. So I haven't got anyone else, so I'm going to ask now, can we note the report in the chat box, please, if you could do that.
Majority agreed, Chairman.
Thank you very much. Keith, I tell you what I'm going to do, because we've had such a very interesting discussion and some very poignant questions which are ongoing. I'm going to see if it's possible, if you would agree to come back at another meeting in July for a short time, just to give us a bit of an update on where we are. If you can, it'd be really helpful. I'm not going to say put you on a hook now, because maybe, but I'm sure, but I'm sure you might want to think about it, and I'm sure that officers will be in touch with you in due course about that. Yeah, thank you very much, guys. That's really helpful. Right. Yeah, we finished agenda item 4 then, so we move on then to the next item. The next item we have, because we're going back to the original agenda, is agenda item 6, which is the Mount Vernon Cancer Review Update. Jessamine, do we have Jessamine? We do.
Yes.
Right, Jess, I don't know who's going to do this. Is it a double act, or is it just yourself, or?
I think I'm going to take you through it, and I know that Sarah's here from Eastern North Herts and may want to add 1 or 2 things at the end.
Yeah, I think it's not a very long item, I understand, so there we are. No. And Sarah's shaking her head as well, so there we are. Over to you, Jasmine.
That's fine, thank you. So I'm going to take the paper as read, so you've had that, and that really lets you know what the latest developments have been since we last came to the committee back in December, with updates around the working that we're doing now with Watford to develop a potential option for relocating the Mount Vernon Cancer Centre onto the Watford Hospital site. For chemotherapy and how we can improve access to chemotherapy, and some of the work we're doing, for example, in Luton around outcomes, and where we are on the transfer. There are a couple of things, though, I thought I would highlight, and particularly as the Programme board had a meeting at the end of last month, so things have moved on a little bit since the paper was written as well. So really just to focus on two things primarily. One of them is the networked radiotherapy discussion, and the other is the continued development of the site. And because I think it's important that the committee is reassured that this isn't a case of abandoning everything and planning for a long-term future, but there's actually a lot going on to make sure that services can still function properly on the site, despite some of the limitations of the current estate and the support facilities that are available. So really just wanting to focus on those areas, and then perhaps one or two of the issues that we are coming across. So first of all, networked radiotherapy then. As it said in the paper, the network radiotherapy discussion is part of the overall discussion. So the Mount Vernon Cancer Centre, as it stands, has one radiotherapy unit that's at the centre in Northwood. The plan is that that would move with the cancer centre to the Watford Hospital site. But there's an acknowledgement that there are still some very long journey times for some parts of the patch, particularly in the east and north of Hertfordshire and in Bedfordshire. And so the process for determining what we did about radiotherapy and whether we could in fact do something was broken down into 3 stages. Stage 1 was looking at all of the modelling. So once we've moved the centre to Watford, if that's what happens, what does that do to the numbers of patients that use it and where they use it from? And therefore, do we still have the same access problem that we do now? Do we have enough patients who would benefit from a radiotherapy unit in a second location to justify having a second radiotherapy unit and make sure that it's safe? And that is the work that was concluded at the February programme board. And the short answer to that is yes. That with the move to Watford, there is still significant concern about travelling times for patients for radiotherapy appointments from the same areas, East North Hertfordshire, and from Luton and elsewhere in Bedfordshire as well. So the stage we're in now is looking at, so if we are able to do a network radiotherapy, and I will caveat it with what I'll come on to later, some of our challenges, which is still funding is not finalised or sourced for this at the moment, and it's part of the overall issue with funding. We're looking at where does that need to be located, and the programme board agreed that the location should be alongside an acute hospital for the network radiotherapy unit, because that enables the radiotherapy service to provide the biggest possible range of radiotherapy. If it was on a community location, it would probably only be able to do the very, very basic radiotherapy treatments. So that basically means that within the area that we're looking at, there are 3 acute hospitals. There is the Lister Hospital in Stevenage, there is Luton Dunstable Hospital in Luton, and there is Bedford Hospital. Now, Bedford Hospital, because the Bedford population go in different directions, it doesn't pick up enough activity to justify putting the radiotherapy unit there, because there is a Milton Keynes service which is subject to a second piece of work. But Luton and Stevenage, there is sufficient activity to have a satellite radiotherapy at either one of those locations that would benefit the populations of East and North Hertfordshire and South Bedfordshire. And so there is now a piece of work underway to determine which is of the greatest patient benefit. And as the start of that piece of work, both trusts have been written to formally to ask to put in an expression of interest. And so that's East and North Herts and Bedfordshire hospitals. And we are expecting to receive those expressions of interest by middle of April, with then another month or so to look into the detail. And we'll be starting some really specific patient activity after Easter to really look into what the impact of either site option would be. So that's radiotherapy. in terms of continued development on the site, I just think it's really important to note that there are ongoing developments. So there is a new linear accelerator that's due to go in over the summer. There has been some work to expand outpatient capacity, and that's largely because of staff and patient feedback about the space that's been available. And there's been some work to upgrade a computer system in medical physics, and I'm sure Sarah can add a list of other things that the trust has been invested in. So I think it's really important that we are aware of that. We are also really trying to step up what we're doing in terms of looking at what can we do sooner. Obviously, there's the main cancer centre move, that would take some time to do. But through the patient engagement that we have done, we've had a lot of feedback about things like blood tests. Really simple example, I had a patient engagement event last night, and somebody gave me a story of a 100-mile round trip for a swab, just to prove that they were COVID safe, so they could come to the site for treatment. And in this day and age, we don't think that is how it should be. And we don't think patients should have to wait for a new cancer centre in order to put that right. So we're looking at what we can do. And for those of you who are familiar with the NHS, that is much more difficult than it sounds like it should be to put right. So I just wanted to kind of assure you that we were doing some work on that. Funding remains obviously a challenge. We're having the right conversations with the right people. But that is something that we do need to resolve before we're able to go out to public consultation. And on public consultation, I think I just wanted to say we've said to the committee previously that we do expect that this will require a public consultation, and we've talked about the implications for the committee and the potential for a joint committee. The dates we've talked about previously, we've said probably not before June this year. I think it's fair to say that there are some elements of the programme that have slipped back because of this second wave of COVID. Largely those elements, we've kept going everything that we can, but largely those elements that have required a lot of clinical input, we've had to acknowledge that the clinician's priority needs to be elsewhere at the moment, and particularly where there's joint working between hospitals. So we haven't published a new timetable just yet, but I would expect it will be highly unlikely that we will be out to public consultation before the autumn now. So I think rather than June, the earliest would be September. And that's affected things like the transfer to UCLH as well, and the decision timetable around that could be a little bit later than we were expecting. So I think that's probably it. We're going to publish some more engagement opportunity events. We are having a lot of feedback, as you can imagine. The biggest issues are around access and parking and what that might look like to Watford, and the Linda Jackson Centre, which is incredibly popular with patients, and what we can do around that. And we are trying to think more innovatively about how we can take some of the strengths of the service and actually make them even better, rather than simply replacing like for like. So I'm going to stop there because I think the rest is in the paper. I'd like to invite Sarah to add anything, if that's all right, Chair, if you'd like to, Sarah. Putting you on the spot, sorry.
I would always like to, thank you. I'll be brief. So I think 3 main points from me. One is we all know there's been a long history of numerous reviews and attempts to find a sustainable solution for Mount Vernon, and this is so far this is making really good progress. There are still some really wicked problems, not least access to capital, but actually it's a really good example of very joined up working between a number of different NHS organisations and commissioners and ICSs. So it's getting a long way, and there is really good, strong clinical as well as patient engagement in this work. So I think NHS England are to be commended for that. The other main point I wanted to make was just to remind those of us that have been around long enough that I think it was back in 2008 when we had the Delivering Quality Healthcare for Hertfordshire consultation. For those of us that have been around long enough, that this committee specifically asked the NHS to do what it could to improve access to radiotherapy when we agreed the consolidation of the QE2 on the Lister site, and we weren't able to progress the new hospital at Hatfield. And this is a fantastic opportunity to try and achieve that. We are working very hard to make as strong a case as we can for Stevenage, as you would expect. The ICS, particularly the public health team, are being very supportive and helping us with that. And it's very clear from the data that given the age profile that we have of residents, particularly in the north of Hertfordshire and south of central Bedfordshire, and that ageing profile, incidence of cancer increases with age, and there is a significant need both now and that will grow into the future. And we will make the strongest case we can. We've identified possible locations on the Lister site. So just want to assure the committee that we are working incredibly hard to make as compelling a case and deliverable a case as we can for Hertfordshire to be able to improve access with a satellite radiotherapy unit in the north of the county.
Okay, thank you for that, Sarah. Can I bring in Dave, who's the first one off?
Thank you, Chairman, and thank you for those reports. I welcome the possibility of satellite units, something that I've campaigned for many years. My wife received very good radiotherapy at Mount Vernon, and it was very successful, for which we are, of course, very grateful. I did get the opportunity to meet many patients travelling there, and they all praised the service that they got, but many had difficulties not owning cars or having people like my wife who could run her there. So I welcome the possibility of satellite stations, something I've spoken to Carver at the Lister and looked forward to. So just congratulations on looking at this. I'm sorry it's going to take so long, but I understand the things that have caused the delays. Thank you.
Thank you, Dave. And I've got no one else to speak, so we'll leave that there. But I would like to pass a comment myself, and I should just share with you that I've already had a meeting with, I've been invited to a meeting with Lister and Nick Carver, who explained to me why they believe that they should actually get the satellite centre. He's in strong conversations with Jessamine, and I'm sure Sarah as well, and they know him well, so they're talking quite a lot. The reality is that we have to. There will be a process. It's a long process. We will be doing a joint scrutiny committee in relation to this, because it affects quite a few of the areas, the health areas. So we can look forward to that coming in the future. It's going to be a long time, but let's not forget that at the moment there's no capital money available. So this could be a bit tricky in relation to the, we could do an awful lot of work here and then end up with nothing. But one thing that Nick did say to me, and Nick Carver at the Lister, is that he is ready to go ASAP if he can, right, in relation to putting a satellite satellite service in the Lister. So he's up and ready and willing. So I just like to leave that there. I don't know if you want to say anything, Jessamine, before I bring Margaret in.
Yes, if that's okay, Chair. Just on that, one of the things that we are mindful of as well is that once we've got beyond public consultation and we've made a definite decision and we've got the money for the Mount Vernon Cancer Centre, we are obviously aware that building a great big new cancer centre will take some time, but that doesn't mean that we couldn't necessarily start some of the bits earlier. So we don't necessarily, we need to sort of work through all the ins and outs, but once the decision's been made, we don't necessarily need to wait for the cancer centre before we can bring in a satellite radiotherapy unit. And those are the kind of discussions that are going on at the moment. There's no firm plan, so I'm not making any promises, but we are very mindful of the journey times and the challenges faced by the populations that we've discussed.
Thank you, Margaret. You'll be pitching, won't you, for the East and North? Over to you.
I will, and I have a long memory. So I was head of public health intelligence back in 2007, 2008. I do remember the disappointment of not having the cancer hospital in Hatfield, and then that recommendation, which I'm very glad Sarah Briley then just has recorded. And because of that history, I do hope there will be money flowing for the Quality for Hearts to improve radiation treatment. But I just want to say thank you very much for this report. This is the first report I've really seen with some sort of concrete flesh on it. I have been very, very concerned about cancer treatment for the last 13 years, really. And so thank you, Jessamy and Sarah, for what you've brought to us today. I also just want to say, although I know it will delay things, I am very grateful to hear about a public consultation, because although I'm also, grateful you've been doing public engagement, I have been told by many how many people couldn't get to one of those. I think that is the right thing to be doing. And I just wanted to say, I do think, the inequalities in health that might have happened actually to do with cancer it's an interesting thing how you're going to measure the health inequalities sort of before and after. But I welcome the things, the outcomes that you're looking towards, and particularly access, obviously, to cancer for Hertfordshire residents that has been of great concern when it's right out in Mount Vernon. So thank you very much for bringing this report. At this stage, it's not easy to sort of pick up. I don't particularly want to criticise it. I actually want to welcome what you're doing so far. So thank you very much.
Great. Jasmine, did you want to say anything, or was it legacy?
Yes, sorry, if I may, just on the issue about patients and people being able to access some of the engagement activities we're doing, we are keeping on engaging all the way up to public consultation. We're not going to wait for public consultation to be doing any more. And we are running about we're running about 3 daytime sessions and 2 or 3 evening sessions every week. So if you come across somebody that's struggling to be able to come to one, do let us know, because there are all sorts of other ways. We're telephoning people. There are a number of ways. We do want to try and hear as much input as possible, and we are just refreshing the way that we are letting people know about the events as well, to make sure that we are getting the word out there.
I was just going to say, because it looks like it's geographically limited by the way it's been presented. I couldn't get to the Welwyn Hatfield one, for instance, when that really would be the one I should have gone to, is what I thought. But if you are opening up every session to enable other people from other areas to come, I think that would be very helpful to publicise that.
Okay, thank you. We will do that. We are encouraging people. We tend to focus on the CCG area that the person is from in terms of some of the data that we share. But if I know that someone on the call is from a different area, I will also cover some of that ground for them. So
that's very helpful. Thank you for telling us that.
Okay.
Good. Right, Richard Thake.
Yes, thank you, Chairman. Chairman, just to echo what David said, as having had a family member, my mother, who benefited from the excellent work that Mount Vernon does, it clearly, it's a valuable service. Look, I welcome this paper. I think it's refreshing to see, even though this is at the beginning of a long journey, refreshing to see that the challenges of improving the health service and continued excellence is being addressed robustly as far as it is possible to do under these circumstances. But I have a question, Chairman, and this is born of ignorance, and I freely admit it, as a relatively new member of your committee, unlike some who have got long memories. I cannot recall what the longevity of Mount Vernon, the current Mount Vernon provision is. I understand, of course, that it's over the border, but there are ownerships which I think are much closer to home in terms of who actually owns the capacity thing. But it clearly, this has been rooted in the fact that the current provision is rapidly becoming unfit for purpose by virtue of the demands that are being placed upon the services across the piece. I understand that, and I just want to be reassured, I think, because I know you will have mentioned this before, and I just haven't picked it up, about the fact that the capacity there will be supported and will continue to be supported until whatever replacement we get. And I think that the proposals here are brilliant. Whatever replacement we get is put in place. And I just think that it would not be a sensible thing for me to sit here worrying about it, because I'll bet many people out there are worrying about it too. And even though you may have discussed it before, just tell me again.
Sarah, can you give us a reassurance here in relation to what Richard has just said?
I will endeavour to do so, and it's a really, really important point that you raise, and the work of the review is very much about the interim sustainability of the service, as well as the long term. So the key issue, I think, or the two key issues are clearly the quality of the estate is really quite frail in a number of places. It's not designed for any of us that know it for really modern, cutting edge tertiary cancer treatment, despite the fact that we get fantastic patient experience feedback from there. Hillingdon Hospital are planning their redevelopment of their main hospital site, and they are the landlords of that site, and so that is part of their thinking. And the other most important driver, for want of a better phrase for us, is that, and I think I'm correct now, that Mount Vernon is now the only cancer centre in the country that isn't co-located on an acute hospital site. And that was one of the key recommendations that came out of the original independent clinical review that was done 18 months, 2 years ago now. So in the short term, there's a lot of actions that are continuing to go into the centre to give assurance around quality and safety, and we do that work jointly with commissioners as well. But I think the positive future and the narrative around a positive future for Mount Vernon is so important for our staff in particular. Really talented, skilled healthcare staff can be quite scarce in some areas. And actually, interestingly, over the last year or so, our vacancy rate has declined at Mount Vernon. We are able to attract more staff than before. There's no cause and effect evidence, but we think some of that is because there is a lot more of a positive forward direction now for the future of Mount Vernon. So I hope that goes some way to answering your question.
Yeah, Chairman, if I may just come back, it goes some way. I mean, I didn't fully expect you to be able to give me a cast iron watertight guarantee, but I'm very clearly hearing that until a replacement mechanism, whatever it is put in place, that support for Mount Vernon will continue.
Thank you.
Absolutely.
Thank you. Did anybody else want to say? Jessamine, you want to say something on that one?
Just to build on that, really. Sarah mentioned that commissioners and provider are working together, and with the prospective new provider as well, obviously, because UCLH, subject to their due diligence process, will be running the tertiary centre in the future. There is a meeting that takes place fortnightly to look at all of the issues and make sure that actually there is a programme to maintain services to the highest quality possible on the site in the meantime. So there is quite an intensive piece of work around the current services to make sure that for concerns like yours, we can alleviate them through that process, partially at least.
Great, thank you. He's giving you a thumbs up. Alison, you wanted to come in. I'm sorry for that bit of delay while there was a conversation across you, but it was very important to drill down into that particular point that Richard raised.
Yes, of course.
Alison.
Thank you, Chairman. Yes, hello, Jessamine. Thank you, and Sarah for your presentation. I was lucky enough to go to one of the engagement events for Northwood area. That was the nearest one to where I live, and I found it very useful. I was slightly sad that there weren't more people attending it, and there's a lot of work for you, a lot of time you put into it, and I wonder if maybe we're all councillors on this committee, if we should encourage our councils to broadcast them on their social media, and but the councillors themselves to be encouraged to go along, because it's certainly very interesting, and I would welcome more people hearing about it. Thank you.
I think I don't think there's any answer to that, actually. No. I think everyone, well, of course we encourage everyone to turn up to all the health meetings that we're public engagement, whatever, anything we can do. This is going to be going for a long while. It's not going to be over very quickly. We've got a joint scrutiny. It's and I think officers Health World have indicated there that we're unlikely to start the ball really rolling until the autumn, winter. And then it's going to be going on a considerable length of time after that, possibly into next year. So I think it's just watch this space, and is the news there. That's what you guys will be telling us in relation to scrutiny and on consultation. Right, Margaret, I think you've got your hand up again. You wanted to come back again.
Very quick one, actually. Sorry, just to do with alignment to obviously West Hertfordshire Hospital redevelopment at the moment, where finance overlaps as to whether, we could actually see a little bit of clarity about the plans in the future. You've actually said that you've already, I think you've got the plans in place for the second site for radiotherapy. Is that right? Or is it still just proposed and there are confirmations still needed?
Before you answer that, I'm not too sure if Natalie wants to come in, because I don't want to get into the discussion about the Mount Vernon and the West Herts Hospital redevelopment. Natalie, did you just want to come in on that and make it clear the separation between them?
I think the question is one that Jessamine can answer about alignment, and I think that's probably as far as we can go today. I'm pretty sure.
Okay, Jessamine.
So the cancer centre and the Watford Hospital development are two separate pieces of work. They're not dependent on each other. We can build the cancer centre if we had the funding for it, on the Watford site. If they don't do anything, they can build theirs if we don't move the cancer centre to them. So in that respect, we are trying to align the timetables as closely as we can, so that for efficiencies with building, and it makes sense to build at the same time if we can, rather than having an elongated building time on that site. We don't have we haven't got to the end of working that through at the moment, so we don't have a plan around that at the moment. Radiotherapy, the stage we're at is expressions of interest for the satellite radiotherapy. So again, we haven't identified which site, and we haven't identified where on each site. I'm sure when we sort of get there, we'll have more information for you. But we are working with West Herts Hospital on understanding their plan, and partly because one of the really important reasons for being on an acute site is to have access to some of those acute facilities that the cancer centre doesn't need of its own, but needs access to. So there's a lot of work going on between the clinical teams, and that's why, because of the second wave of COVID, it's taken a little bit longer, because those clinical teams need to talk about what that looks like and what the requirements are around that. So that's where the two are kind of dependent on each other, but the two new builds themselves aren't. So they are the Watford Hospital funding does not include the Mount Vernon. It will not include the Mount Vernon. We need to find our own source of funding for that. And as I said, we can't go out to public consultation until we've got that sorted out. So that will be something that we'll be starting to press more for over the next few months as we move forward in those discussions. And I think having a really strong clinical case and having a plan really helps with the discussions about the money. It's really difficult to have those discussions when it's a vague, well, we need to move it to an acute hospital site, but we're not sure where, we don't know what it will look like. The more details we can get, the more constructive those conversations are getting.
So funding in the timescales for the cancer side, the development of Mount Vernon, you're hoping to sort of get those in place in the next, or before September, if you want to do public consultation in September. Is that right?
That's right.
That's helpful, because I didn't quite know when the sort of funding deadlines were likely to be.
If we haven't, then the implications of that are a delay to the public consultation and therefore a delay to the whole programme. Yeah. Unless we are told no, never, we will continue to progress with some delay. But we're working on the assumption that we will find a way of resolving that one before September, if with a fair wind.
although they're separate, there should be cost savings by doing things together, actually, even though I know are separate funding streams.
I think it's too early to identify that at the moment, because we haven't even developed a plan in terms of what the cancer centre needs to look like, and they're just so far ahead of us at the moment that actually once we start to move forward with the Mount Vernon plans and align things, I think that's where we might see whether there are those kind of opportunities.
Okay.
Exciting 3 months ahead then.
Definitely.
Yes, indeed. It is. It always is exciting in the health world. Listen, gentlemen, thank you very much for that update and presentation there. We're asked to note it, so can we all note it in the chat box, please? All right, have we got there yet?
Majority agreed, Chairman.
Yeah, thank you. It's very difficult sometimes when you're looking at the chat box, because the names and the agreed it flicks up very quickly. So sometimes you're not 100% sure. Sometimes I'm not 100% sure whether that's been agreed. But the eagle eye back at the ranch in County Hall has told me that we've got to the majority. So we will do it. So thank you very much for that. Now we move on to agenda item 7, West Herts Hospital Trust Health Infrastructure Scrutiny. You may recall, colleagues, that we delegated this down to a topic group to determine this particular item. They've made their decision. There's not much we can say about that. The only thing as I can say is that, and there's no discussion on it, but what I would like to say is that Ron Tyndall contacted me before the meeting and said that he had a point of information he wanted a point of information how we are going to manage this process of scrutiny moving forward in relation to the West Herts Hospital Trust. I think I've got that question right, Ron. I'm going to allow that question. I'm not going to allow any further discussions on this particular item. So, Ron, did you want to come in and confirm that question is correct in relation to the way I put it?
Point of clarification, really. Yeah. There are still a number of public residents that wish to discuss further matters, obviously not today. And I would like to ask, what is going to be the process going forward? What are the future forums for residents who still may have concerns to raise them for consideration?
Okay, I will take that and pass it to officers. Which officer wants to give it? Is it Natalie or Louis? Natalie or Louis? Which one of you?
I would say in answer to Ron's question, I'm sure that the CCG and the Trust themselves will continue to run the suite of engagement events that they have been doing. They did give an assurance at the topic group that Ron would have heard that they will engage with the committee going forward, as we've required of Princess Alexandra as well, so that the committee continues to understand what developments are. And then it will be for the committee to determine the regularity of that and the content of that as we move into the new committee following May's elections.
Okay, thank you. I think that is fairly clear.
Thanks very much.
Colleagues, as the topic group made recommendations, and it's very clear those are recommendations, what they are, I won't allow any discussions on the outcome of that particular topic group. I'm now going to turn around and ask you all, can you note the report?
Yeah, Chairman, just one point. There's a slight spelling typographical error. Infrastructure. It should be infrastructure. Should slightly.
Oh, well, I blame the chairman of the topic group for that.
You may blame who you like, and I'll accept blame. But can I ask Natalie to get it just
Yes,
corrected,
of course.
so that we?
Of course.
I'll take it.
Yeah. Of course. Sorry about that, Richard. Okay, thank you very much. So you're all it's coming in now. The voting's coming in. Okay. And again, would someone tell me when we get to a majority?
Majority agreed, Chairman.
Oh, brilliant. Thank you very much. Right, so that's agenda item 7. We now move on then to agenda item 8, the annual patients experience scrutiny. Natalie, are you going to present?
Yes, this is just a reminder to the committee that although we weren't able to undertake it last year, the annual patient experience scrutiny will take place after the May elections in July. And drawing on experience of the last time that we ran it and some challenges that we faced with the IP scrutiny earlier this year, the paper proposes that the questions that the committee has already agreed, which do have that COVID focus you were looking for, those will stand. But the suggestion is that we follow a model which is close to that when you've undertaken budget scrutiny, which is that you will hear from the participating organisations in the meeting itself, which enables everybody on the committee to hear the questions and the responses. And it also gives us the opportunity to live stream it, because I know that members have raised at full council the couple of meetings which are held in camera are, if at all feasible, to be held publicly, that we do that. So the model that I'm proposing enables you to do that. I'm also suggesting that we just draw back slightly and reconsider the focus of which organisations are called to be scrutinised as part of this activity. Over time, the numbers have increased and it's become incredibly difficult to manage the complexity of those number of organisations. So the proposal in front of you is that you hear from the ambulance service, which is in special measures, mental health, because of clearly what was articulated in part this morning was the issues facing the mental health trust post-COVID, and patient care being a key issue within that, and that you hear from the 2 acute trusts within this integrated care system that are likely to be receiving Treasury and NHS money to develop their estates. So that would be West Herts and Princess Alexandra. However, that said, the other organisations, the 3 other organisations, would be required to complete the questions that everybody else is being asked to do, so that you would have the complete picture and be able to draw on that for any future scrutiny. The model proposed does mean that we would be able to undertake scrutiny in one day. And the advantage of this is that it then releases the second day of the scrutiny, which is the 21st of July, for any committee business. And as you will have a new membership next time we meet, it may be helpful to have that July meeting to undertake some of the committee's business. I suggest I leave it there, Seamus, if that's okay. And then if members have got any questions or points of observation, that I respond to those, if that's okay, Seamus?
Yeah, that's fine. That's great. I think you've covered everything. Margaret wanted to come in. I think the advantage of leaving it as it is getting the clear free day in July, which will mean we will be able to sort of do some work. If we bring more people into this and expand it out, we're not going to have that capacity. We will definitely won't. So anyway, Margaret, over to you. I can't hear.
I don't know.
Thank you.
Sorry, can you hear me now?
Yeah, we can, Margaret. We can hear you clearly.
I have a concern, and I know the chair and Natalie know this already because I brought it up in the briefing, that this is a patient experience scrutiny, and that we should be balanced across the whole of Hertfordshire in how we conduct it. So in choosing just, well, the 2 hospitals that are going through a HIP for redevelopment, or, I mean, I do understand obviously the ambulance trust is very important to scrutinise, and I agree with Herts Partnership, but I do think we should include East and North Herts as well, because in COVID there have been some experiences that I think we should hear about. Now, I'm a little concerned that it sort of feels a bit unbalanced, that it's sort of West Herts for reasons that I'm not sure are really currently relevant yet, but you know, because it's all to do with the development in the future. I just would like Natalie to sort of justify why she's left out East and North Herts particularly, and if it's not on July the 7th, that we at least get the feedback from them before July the 7th, and then we possibly raise it as a matter of business for the 21st of July.
Okay, Natalie, over to you.
The committee were very clear in the discussions leading up to the scrutiny that they wanted these to be a COVID focus, and additional to being part of the HIP programme, both West Herts and Princess Alexandra were subject to more COVID pressures. All hospitals, acute hospitals, struggled with COVID, but West Herts and Princess Alexandra were particularly challenged during COVID. So hence another reason for that, for their inclusion within this. To be clear, the request for the written response to the questions will go out to all organisations at the same time. All of that information will be returned at the same time and will be distributed to members at the same time. I would suggest that it could well be difficult potentially to look at that at the 21st of July, and whether it might be more sensible to consider that perhaps in the autumn, because I can think that there will be quite a lot of items to be taken on that July meeting. And there is an argument that if you were going to be considering any of the organisations that aren't attending on the 7th of July, if you are going to be calling them to the 21st of July, you would just include them in the programme.
Yes, sorry, Chair, could I just come back?
Yeah, come back.
So I feel that it's a very qualitative statement that you've made, that you know, you thought that West Herts and Princess Alexandra might have had more difficult experiences during COVID, but I think I should bring to your attention that the QE2 had a total change of use during COVID, that it was a walk-in centre, and those regular activities that were dealt with as a walk-in centre then didn't get covered because it became a COVID specialist centre. So East and North has had difficulties too, and I would argue that that should also be included on July the 7th, and I agree that it would be natural to include it in July the 7th rather than making some special measure for the 21st of July, but I do think they should be heard.
It's a decision for the committee, Margaret, and the statement about West Herts and Princess Alexandra is quantifiable as well as qualitative. The pressures that were experienced by Watford and Princess Alexandra were of a different magnitude to what was experienced at East and North. It's entirely the decision of the committee. If you wish to include any other organisations, that is down for you to determine that. What I would say is there would not then be the capacity to run a general health scrutiny committee where you've already identified you might want to hear from HPFT. There would not be the capacity to run that on the 21st of July. It's just a balancing act about what you want as your priority for the 7th and 21st of July.
Do you mean the 7th? There wouldn't be capacity on the 7th to do 5 rather than 4?
There would not be capacity on the 21st to make the timetable work, and it would be difficult. It would need to run across the 21st, which would remove the ability to run a more or less standard agenda for the 21st of July.
Okay, no, look.
Should we vote on this then, please?
Yes, we will. We're going to vote now. We've heard what the officers have said. We've heard their recommendations to a certain extent that we run it as it is laid out in the papers. Margaret is not happy. And what I suggest we do is we vote on whether or not it's agree or disagree on the recommendations in the papers, the way the papers are saying it. If we disagree, we'll then come back and we're after the vote, and we can have a chat through how we're going to deal with it. That's the best way of dealing with this. The officers made it clear that if we agree, we will be able to do it within capacity. If we disagree, we will potentially have a problem with capacity. But we can get back to that afterwards. So it's agree or disagree. That's what I'm looking for. Okay.
Okay. Thank you.
That's the fairest way of dealing with it, isn't it?
Majority agreed, Chairman, 2 disagree.
Okay, so we're going to go ahead with that timetable that's laid out in the papers. So I presume, should we vote again on the papers itself? To note the papers, can we vote on it again? Do you think, to make 100% sure that we've got this right? Can we
need to, Chairman, because essentially that was an amendment, and now you got the authoritative. Yeah.
That's right. That's right. So we now need to agree to note the papers or not agree. So can we agree? Can we vote on that in the chat box, please?
Oops. Majority agreed, Chairman.
Thank you. So that's agreed. So we now move on to agenda item 9, which is the scrutiny work programme, and it's Fiona. Where's Fiona? You're always last, Fiona.
Yeah, I'm here, and I'll keep it quite brief. Thank you, Chairman. So it's your usual regular work programme item. And I suppose for this meeting today, you'll be keeping in mind that the decisions you make today on the work programme will sort of provide a helpful legacy to the incoming committee in May after elections, and hopefully mean that the scrutiny work can continue without any delays. And having said that, I'm aware that both this committee and the Overview and Scrutiny Committee have worked hard in recent months to review and prioritise the work programme, making sure that topics are relevant to the current context, particularly with reference to the pandemic and its impact. So that's what you've got there with the whole scrutiny work programme. Just a couple of things to highlight. They're not. So first of all, the paragraph 2.10, the ISAC Impact of Scrutiny Advisory Committee. There's just a bit of an update since papers were published, and so I can just say on behalf of the chairman of the ISAC committee that the results of the 3rd of March meeting are that the committee agreed that all the Hertfordshire Safeguarding Adults Board recommendations, there were 3 recommendations, and they were all accepted as complete. And with regard to the Children in Care Council mental health scrutiny, due to the pandemic, the recruitment of a manager whose role it was going to be to take forward those recommendations was delayed. So those recommendations are going to be considered by the Impact of Scrutiny Committee again in June and September this year, where officers have, given assurances that there'll be progress to report then. So that's just the update from the ISAC committee. And then just to let members know, in reference to the joint work programme Appendix 1A, last week the Overview and Scrutiny Committee met and agreed a few additional items which are now added to the work programme but aren't on the papers that you've received. and they don't fall within the Health Scrutiny Committee remit, but I just thought it was good to update you to, for completeness and to sort of give you that full overview. The following items, they all arose from this year's budget scrutiny, and they've been the Overview and Scrutiny Committee agreed to add them to the work programme. So one is flooding. The second one is assess the impact and financial cost of bringing the household waste recycling centres operations in-house. Equity and consistency of catch-up provision for pupils across all types of schools following lockdown. And finally, effectiveness of increased care worker pay from 1920 to 21-22 on recruitment and retention. And that one to be scheduled in 2022. So all of those were agreed to be added to the work programme by the Overview and Scrutiny Committee. And some of you might have been involved in the budget scrutiny, so you may well have been involved in those coming through. So that's all I wanted to say. Thank you, Chairman.
Thank you, Fiona. Thank you for all your hard work over the years, sort of in relation to this. Colleagues, does anybody want to say anything about the work programme moving forward? No, doesn't look like it. Right. Okay. So we agree to. Well, no, we don't have to note it, do we? Oh, vote via chat. Yes, we do. Guys, we've got to do it again. Can we agree it via chat?
Majority agreed, Chairman.
Thank you. We now move on to agenda item 10, which is other part 1 business. Yeah, there isn't any, so that's that. That says it all. 11 is items for reporting to the County Council, standing orders. That's to note all items on this agenda will be reported to the County Council. The next meeting of the Scrutiny Committee is the 7th of June. And it now comes, there's two little bits that I want to say now. I think it's fair to say. One is in relation to ourselves and the committee. I'd like to thank everyone that's worked during this session of the actual cycle of health scrutiny. You know, you're a very experienced team, and I'm hoping we could all stay together. We work in a non-political way. We do it very smartly. And I believe, you know, you all deserve a big clap on the back because you all are brilliant when it comes to health scrutiny. So I'd like to thank you all for having a great input over the last 4 years and for doing your bit for the community. You've left it in a better place than when you found it because of your involvement in scrutiny. Now, the other thing I'd like to say is another good bit of news, and it's the last thing I'm going to say today, and that's it's an interesting thing, but I got to say it. Prince Philip, he's left the hospital and gone to Windsor Castle. So I think that's really good news for the country generally. We all need some good news now. It's been a difficult year, but anyway, he's on his way to Windsor Castle now, and we wish him luck in the future. So I just thought I'd say that. And the last final point is to thank all the scrutiny officers for all the work they've done for me and the team and for Chris and for all you guys over the last 4 years as well. So that is it. So I'm going to say goodbye and thank you all for being here and working hard on this particular committee. Thank you.
And thank you, Seamus, for